You may have heard the abbreviation RCM, which is Revenue Cycle Management, in your journey to becoming a medical coder. But what is the revenue cycle? Well, that's what we're going to talk about today in this video. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator, and on my channel I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, highly encourage you to subscribe, hit that notification bell so you can get alerts when I post new episodes. Now, if you are interested in a job within the revenue cycle in medical billing and coding specifically, let me tell you about my medical coding masterclass. I get all of these questions about billing and coding schools, which one to go to, what to look for, and that's what I talk about in this masterclass. What are the things you need to know when you are looking for a medical coding school? And then I give you the details on the best school you can go to that is going to fill all of those needs. I cover all the things I've learned since 2007 on like the right way to get into billing and coding, what are the credentials that employers are looking for, how you can do this without getting into student loan debt, and how you could possibly get a free laptop with your program. But you have to sign up today to get that full roadmap on what you need to do at my link in the description, medicalcodingmasterclass.com. So the revenue cycle, it encompasses everything from creation of that patient account and that whole journey that a claim takes from being created to getting paid. Healthcare organizations have to have a very efficient process to manage all of that financial information that comes from getting that patient registered, scheduling them the right way, making sure that we're getting that insurance payment and the follow-up from that. So these healthcare organizations have to monitor all these activities, make sure that everything is being applied correctly, compliantly from the creation to the end of the cycle. So really the key factor in having a successful revenue cycle, aside from the usual things like communication and having good employees, is being to identify those areas where we may be leaking revenue or leaking money. Money is not coming because of a certain reason. And we'll talk about some of those reasons why you may leak revenue. So being able to identify those and figure out how to correct them. There's this saying that I used to hear that all roads lead back to coding, and that was kind of true in the revenue cycle. Like when we didn't get paid or when something was denied, people would go, oh, well, there's codes on this claim, so it must belong to the coding department for them to fix. But denials are not all about coding. They can happen at any point there during that journey of the claim, even at patient registration. That's actually the first step of the revenue cycle, is that the patient is registered into the system. We put in their name, their date of birth, their demographic information, and their insurance information. And if the insurance information isn't put in correctly, or even if their name doesn't match their insurance card, that can cause a lot of denials before we even get the codes assigned to that claim. Believe it or not, actually in my past as a coding supervisor, one of the tasks that my team and myself personally would handle would be sometimes going out to front desk staff in the practice to train them on advanced practitioner billing, because there was a lot of misunderstanding about how to read the grid for things like Incident 2 and how to bill under advanced practitioners, what that looked like in the system based off of the different insurance guidelines. Some want you to just bill it under the provider, some want you to bill under the advanced practitioner. Advanced practitioner, when I say that, I mean non-physicians, you'll sometimes hear them referred to as, but I prefer the term advanced practitioner. Sometimes you'll hear them referred to as mid-level providers. So they're not an MD or DO, but they're someone like a certified registered nurse practitioner, a physician assistant, or a certified nurse midwife. And because of all the nuances with Incident 2 with Medicare versus how we bill advanced practitioners for our commercial insurances, those can change different financial aspects. Sometimes you can bill it out a certain way as though the provider saw them and get 100% of the fee schedule, but a lot of insurances reduce the pay if it's just the advanced practitioner seeing the patient. Now, one of the next steps in the revenue cycle is to verify the insurance, and there's different portals that you can use to validate the insurance. A lot of times they'll run maybe the night before or a couple of days before the patient is seen. If you have time, if it's not a situation where it's an emergency, the patient's coming in that day. And this is where we can do things like identify if maybe the insurance has terminated and the patient has a new insurance now or has no insurance coverage, or if based off of different criteria, there should be an insurance that pays first. Like if the patient has a commercial insurance and they have a Medicaid insurance, Medicaid is usually the last payer. They don't like to pay anything before everyone else does. So making sure that the insurances are paid in the correct order. So we've got the patient registered in the system, we validated their insurance, they go in, they see the provider, and they have some sort of service. It could be an office visit, it could be a surgery, it could be anything. Then we have to capture the charge. So in a lot of large organizations, providers will capture a good amount of like office visit charges because there's just so many of them. And the risk sometimes is low enough that they can just be sort of spot checked or monitored by someone. So a lot of those they will flow through and be billed out automatically. A lot of organizations, things like surgeries or things that are high dollar or high risk will go to a coder to be coded. So the coder will sit, review that whole record, abstract the appropriate codes, ICD codes, CPT codes, HCPCS codes, and then bill them out appropriately to go to the insurance. I've had a lot of providers in larger organizations make comments to me like, oh, well, you probably see all the things that I'm billing out, so they're probably okay. And the insurance, they're reading all those records, and that's not what happens. In most cases, when it's things like E&Ms in large organizations, private practices, smaller organizations, totally different. But in larger organizations, a lot of those are just going through. There isn't someone reading every single report for every single 99213 or 99214 office visit service that a provider is billing. And I'm going to talk more about the insurances in just a second. So, the bill's been generated, it goes to the insurance for payment. If it's a clean claim, they look at everything, they go, yep, this is a service that we pay for, this patient has this insurance, everything looks good, we're going to pay it. So the payment gets posted to the patient's account. And then if there's a contractual adjustment, like they bill $300 for the service and the insurance pays $200 for that service, and contractually that's what they've agreed to pay, so the rest doesn't go to the patient, gets written off. Unless, of course, the patient has a deductible or a co-insurance or a copay or something that needs to get paid. Now, if there's an issue, the claim could get denied, and that means the insurance is not going to pay it, or at least not at the way that it currently looks, and that has to be looked at now by someone. They have to go, well, why the heck did the insurance deny this? Because there's a variety of different reasons why a claim may be denied. So that's when the billing department or accounts receivable tracks that claim. They look at that and they determine what they need to do about that, because it could be a variety of reasons. And actually, you may have heard the term adjudicated when it comes to claim. Has the claim been adjudicated? And that's when it's been reviewed by the insurance company and determined if they're going to pay or deny that service. Sometimes claims are auto-adjudicated, which means they go through that computer processing where they go, oh yeah, we pay for this CPT code, this patient has a valid insurance, they meet the frequency requirements, it's the valid diagnosis code, et cetera, and based off of those programmed criteria, they just go, oh yeah, automatically we know we pay this amount of dollars, and they send it out to the healthcare company. Because of the huge amount of healthcare consumption, the huge amount of claims, not everything is individually reviewed by a flesh and blood individual. A lot of it is just automated, that they look at the different criteria on the claim and go, yep, this is something we pay, or oh, nope, this is programmed to be something that we don't pay. And it could be as simple as maybe it's just a service that should not be covered. Maybe a claim went out to the insurance for a cosmetic procedure. Well, your health insurance isn't going to pay for a cosmetic procedure unless there's a medical necessity for it, so they might just deny that claim. Or they might look at it and they only cover a certain type of procedure for certain diagnosis codes. You don't have one of those diagnoses listed on that, so they're going to deny the claim. So a huge amount of claims are potentially going through, being submitted, and being paid or not paid without being reviewed, although that always can come into play later on in audits if the insurance company maybe notices an unusual trend. You're billing a very high volume of claims or a lot of high dollar claims, or there's something that they know tends to be abused, maybe like a modifier 25, and they see you're billing a lot of stuff with modifier 25. They might come in and then say, hey, we're going to do an audit. You have to send us those records now so that we can review them. I've often heard providers or even people scarily working in the revenue cycle say, oh, well, the claim got paid, so that must mean it's okay because the insurance paid it. Not necessarily. There's been tons of cases. I've had some very locally, know people that have worked for organizations where it's happened at, where things got paid and paid and paid and paid and paid, and then one day, boom, an audit, and the money got taken back. But as far as if they're denied upfront, they can be denied for a variety of reasons. It could be because the patient no longer has that insurance. It could be because we pre-authorized one type of procedure saying, yes, this is the CPT code for the procedure that the patient's going to have, and maybe something changed. They had a procedure that has a different CPT code, so they said, hey, you didn't have this authorized, and we're going to deny it. So when the billing department is looking at all these denied claims, they kind of have to prioritize some of them. And typically what they do is they prioritize two main things, like high dollar things that like, oh gosh, this needs to get worked because it's very expensive. We don't want to lose this huge amount of money, or it's aging claims. Insurances will often give you a time limit on how long after they've made their decision that you can appeal that decision and maybe correct the claim and resubmit it for that payment. And that's different than timely filing. Timely filing periods is how long the insurance says, oh, this is how long you have from the service being rendered to us getting that claim to us. So they might say, okay, you have to see the patient on this day, and then within 90 days you have to get that claim to us, but they might have a different time period for when you can appeal that. So say that claim is denied, you might have a different time period of how long you have to appeal that claim. It could be 365 days, but they want you to get that initial claim in within that 90 days. Now, in these large organizations with these large revenue cycles, you'll often find that some different types of positions or job functions might fall technically within the revenue cycle department, like provider enrollment or credentialing. Credentialing is that process that organizations go through to make sure that providers have the right licenses in the right areas, the right skills, the right credentials to provide services to those patients. Enrollment is the process of having that provider be enrolled in various insurances so that they can see patients that have certain insurance programs like your Highmark, like your Aetna, like your UHCs. Revenue leakage is a problem in healthcare, and it can be solved by a lot more than coding. In order to really identify those leaks, it's really important to have good communication with all different components in the healthcare process: the registration, the scheduling, the pre-authorization, the coding, the submission, the follow-up work. You can also check out this video on provider RVUs and reasons why they might be low, which does also have an impact then on the revenue cycle. I will see you guys in the next video, and until then, just keep on coding on.